This is our last panel together, and it's really been quite a weekend, starting with Diane on Thursday night. And I'm sure that all of you have a lot of questions. I mean, the issues that were brought up during yesterday's panel about the demographic push, the change that's happening all around us. And we're like in the midst of this incredible change that's going on. Roseanne asked in the last workshop that Diane did, how can we help? How can we help him? Speaking of a doctor in an example. But I just want to say, how can we help make this change so that it is a change that comes from wisdom? I think all of us, whatever our role in this world is, that's our intention. I mean, I think that's why we showed up this weekend. So I think that's the question I'd like to first pose to the panelists, just kind of briefly, and then bring it out to the whole group. And maybe start with Chodo on the end. Scared to, I know.
What's the question?
Go back to that room where the little girl was and the father. And how can we help? How do we help? And then we'll go systemic.
Mm-hmm. I think it's really a matter of what we've been talking about all weekend, and that is noticing and being fully aware of what is happening. What is happening with you, what is happening with the patient, the family, the doctor. What can we do collaboratively and not demonize, separate, not make, that's what doctors do, this is what we do, if only they did it this way because we do it this way, to not go to that place anymore. And I think I think that has happened over the years, that doctors have been given this kind of identification, and then we come in as social workers or nurses or physician's assistants, and we want to do really well for the patient. We want to do the best that we can because we're coming from a different mindset. And whilst we're in that mindset, it's very easy to make the other wrong. And we have to be very careful that we don't do that. I think that's the wisdom piece for me, is that we're actually all in the same boat. It's just some of us are in steerage and some of us are in first class, you know. It's like but let's not make the boat the Titanic, you know. Let's really do this beautifally. Does that help?
I think that's helpful. Maybe you could say it.
Well, picking up on that, I think what you're calling for, if I hear it correctly, Chodo, is compassion. And we should be really, really good at that. So appreciating all that doctors have gone through to get to where they are, and some of the hangovers and the rules that they're playing out, at one time served some great purpose. And they're just sort of misplaced often now. So I feel that a lot as a doc. You know, I went from feeling, you get too much credit, to now I'm just sort of some sort of demon. And it's not particularly fun or even helpful. But anyway, besides that, I just think there is a call now. We have an organizing thread that's larger than any one industry, larger than any one sort of field of study. So we should delight into that. And it's something that affects everybody. You know, 100%. Again, I keep circling back to this idea that 100% of us are going to die. That is just, I know it just seems kind of silly even, because we shouldn't even need to say it, but I guess we do. And that's part of its joy, is this connecting force. Not only that we're going to die, but we have this strange human capacity to ponder it before it happens. And that we as future-oriented beings will run out of a future at some point. And that is a common thread across cultures, across age, across wealth. So it is the perfect integrative thread to follow, and it's right in front of us. So I think you're just staying true to that larger cause will pull us out of our silos, and pull us together in all sorts of ways. And that's not meant, it's not going to be conflict-free, nor would I even want it to be, because we need to sculpt ourselves over time. So sort of embrace it, welcome it, and again, I think a basis to make it all possible would be compassion. Not just towards others, towards those ogurely docs, but towards ourselves too, because we're going to fail a million times along the way.
Thanks, BJ. Diane, you have something to add?
I just want to pick up on what Chodo said about noticing. And here's where something that psychiatrists call countertransference comes in handy. Where when you walk into the room, you start feeling things. And what you're feeling are data. And for the most part, they are mirroring the feelings of the people in the room. It's really amazing how much gets transmitted without a word being exchanged. There's that statistic that gets thrown around that 70% of human communication is nonverbal. But you really can tell when you walk in the room what's going on, even if you can't put a word on it. And it is data for you. But it requires walking in with this stance, this noticing stance of, it's almost like you're doing a physical exam or taking a history. You're paying attention to the feelings in the room and how they're registering with you. Because what you're feeling is what they're feeling. So if you're feeling like, I wish I could get out of here and run, go home and get under the covers, that's how they're feeling. If what you're feeling is, I'm looking forward to this conversation, these look like really fun people to talk to, that's how they're feeling about you coming in. And it sounds very simplistic, but it is really true. So that if you're walking in with this curious noticing stance, you have a lot of the information you need to be of service. So I think that's all I want to say.
Pretty good. I think one of the things that's really important to me is the sense of, I want to go back to this ethics and the ethical charge that I think that we have if we're going to really call ourselves mindful or contemplative or Buddhist practitioners or combining this into care, that we have to really, I'd like to start a campaign to get rid of the term self-care, actually. Anyone to join me? Meet afterwards. I think it's really for the birds. And it's because it really takes out this interconnection that we actually experience. When we're really in the work, it's not about me, my care, or you and your care, but it's about how do we function in a caring way? How do we develop a mind of care? And that, to me, is only, in my experience, maybe there's probably a lot of other good ways to do it, but I found the way of meditation. But whatever it is that really roots you and makes you feel connected, whether that's prayer or a yoga practice or whatever it is, but for that to be completely interwoven into those weavings that Roshi talked about, of intimacy. And so while we're walking into that patient's room and feeling something, that we can actually rest in that. We don't have to move away or react, or we can notice our reaction and to come back. And I feel like that's the way that we can care in a very clear way. So that's all I'll say for now.
So something Diane said in her workshop about modeling the behavior, that's what I'm hearing, is that when we get on the actual level of when we're when we're walking into a room, working with a patient or family, that we're modeling a certain kind of way of looking at meeting pain, meeting dying, meeting life, being a person. And that that's on the personal level. Is it enough for us to model that for the systemic level to change? Is a question that I ask a lot. My work is more often with the homeless. A lot of pain on the street. And I had heard from Craig about pain clinics and how, I thought of all the people that I see that are just, they're drunk or taking drugs because they're in such pain. And our whole system doesn't even look at them in terms of this. So that's just another flag I'd like to offer. And then I'd like to hear from you, ask questions of anyone here on the panel, or make remarks, or what your feelings are about this world that we're in and what we can do about it. A hand back there.
And one here.
Oh, and there's one here.
Right there.
Hi. I am so appreciative of this gathering and this conference, and I have enjoyed talking to the people I've talked to, and wish I could have talked to most of you, almost all of you. And I wanted to add one thing to what Diane had to offer about when we walk into a room and with the curious open stance, and also that whatever we find in there will be okay. That, not that it has to be fine, but that I will be okay with whatever they have going on. And that's been an important way for me to walk into a situation. The other thing that I wanted to offer as a question is, when taking this forward, that we are, in this group, an amazingly attractive and intelligent group of people. There's no denying that. We're also all the same looking. And I don't know how to help involve people who can't afford to be here, people who have language barriers, because they're the people who are washing our patients, and if there would be a compassionate way to invite them into this meaningful dialogue, would be super duper.
Very similar comments. This has been a wonderful conference and wonderful to hear all the comments from the panel. I think one thing that I've found as a neonatologist is simply reframing the situation. I can't tell you the number of times I'll go into the intensive care unit, hear a presentation about how we can do this for the respiratory system, this for the cardiovascular system, this for the GI, this with feeds, listen to the whole shebang, and then simply say, what are the chances this baby is going to make it? Oh, not good. Yeah, about 0. So what are we doing? And then the team automatically, as soon as that veil is lifted, the wisdom shines. It's unbelievable. And the practitioner is on the thing. I was like, well, I've gotten rid of all the heel sticks, all the pokes, so we'll do more labs. And I'm going to DC all these meds, start morphine every 2 hours, and Versed every 2 hours. And it's on a dime. It's instant. As soon as the veil is lifted, everybody knows what to do when the wisdom is there. And it happens all the time. Simply debriefing and walking through a situation, and how are people feeling about this ethical dilemma of us poking this baby because the parents aren't ready. You simply allow that space in the unit and things shift. And to your question as to whether modeling makes a culture difference, after 10 years in one unit, it's there. It really feels like our unit now knows how to do that. And it doesn't take any one person anymore. It can be anyone saying, what are we doing? And it is amazing to watch, because it's simply the right thing to do for these babies.
I just, yes, I think all of us who work in a teaching environment do feel what Charles said, which is that bringing this approach to the bedside transforms the culture of medicine. I just wanted to say that how do we bring this from the immediate human-to-human core or heart of what healing and healthcare is about to a social change level. And I really think it's as simple as looking at other entities in our society as we would another human being. And we were just talking earlier about trying to get this done in Vermont. An ER doc, one of the people here said, you know, all I do is see the same 5% that drive 50% of spending. They just keep coming back. What do we do about it? And it's exactly the same thing that we've been talking about. It's reach out to your peers on the other side of the hospital door, whether it's the home care agency or the federally qualified health clinic or the hospice or the nursing homes or the assisted living facilities, and actually bringing people together as a community that is serving its community and asking those open-ended questions. What are your observations about what's going on? What do you think are the root causes of people coming in and out? Because the solution is community-based. It's not individual, and it's not within a hospital or within a home care agency or within a nursing home. It has to cross those boundaries in order to work. And then, of course, the question is, who's going to pay for this? And, you know, here I'll just be very pragmatic and ask you who has a financial interest in having this work better. And it's the payers, and it's the state, and it's the employers. So that's who's going to pay for it. If the providers in a region come together and say, we have a consensus about what's going to work well for our community, and we'd like funding to pilot this approach, I can tell you that there's a very strong financial interest in your success on the part of the people who pay for all this health care. So that's yet another layer of partnership that has to be established once the providers are unified in a coalition. But it's the same technique, just at a different level.
Maybe one quick comment while I still have the microphone in hand is, after introducing perinatal hospice into our hospital against a great deal of resistance because no one wants babies to pass, my chairman came up to me and said, "You would not believe how much money this is saving. You really need to write this up." And I was like, "Not really, not, no." I mean, if you take a baby who has a lethal anomaly, you intubate them, give them drugs, put lines in, get an echo, put them through heart surgery, put them through gut surgery, put them through TE fistula surgery. It costs a lot of money. So first day of life care or second day of life care, so the chairman came and said, "You really need to write this up because it saves money." I was like, not really my approach on things, but but it was a change that just came from the bedside up, which is neat.
Thank you. I'm not in the field yet. I don't know if I will be of palliative care, but that's why I came this weekend, was to find out what it's all about. And I'm feeling very overwhelmed and discouraged because the systemic blocks seem so huge that I think, well, there must be satisfaction on the other side, or these people wouldn't be doing this. But it raises a big question for me. It's not a no, it's just, or yes, it's just a question of, should I really go into this field? I was thinking of taking the foundations course through the Zen Institute, but this is where this leaves me very pained, really. So I'm just putting that out there.
I just would want to say, this come up in some conversation on the side, that this work, for all the daunting challenges to it, there's so much beauty in it, and not an abstraction, in an immediate sense that you would feel on a day-to-day basis if you're trained and supported for the work. So, and we can't let it become a sacrificial pursuit. It's already too much of that, burnout being great evidence of that. So that's one thing that a lot of us are pushing for, is sort of how to train people and support people to do this work, how to be fed by doing this work instead of this sometimes called pathologically altruistic work. That the empty you are as a provider, the better off your patient is. The less of a personal life you have, the more evidence of your commitment. It's sort of outdated, thankfully. So anyway, there'll be plenty of beauty along the way for you to be fed by, especially with proper training and support. And this is something that's so daunting, it's so huge. It would be, it's going to be something we chip away at it from multiple angles. And I think we can't be above anything. As Diane's pointed out, politics enter into it, finances enter into it. We are an epiphenomenological thing above that, sort of trying to kind of bring a bunch of things together. But I think medicine in particular has gotten a lot of trouble by being above the fray of the finances. And then we just outsourced it to somebody else, and that became the insurance company, so for example. Anyway, I can go on and on about that, but maybe I'll kick it over to my right.
I guess I would say, of what value is an unexamined life? I mean, the fact that we can't solve this problem tomorrow or even in our lifetime doesn't mean it's not the most valuable, worthy place to be. It's how we are as a community, as a society. What are the ends of a society? We are about trying to answer that question by saying it's about how we care for one another. So the work is so worthy that it is its own reward. It's not about the outcome. It's about being on that path. It's about the path.
Yeah, so it is the path, right, itself, right, in some ways. And I think also, Oedipus got in a lot of trouble when he solved the riddle of the Sphinx. So sometimes we have to it's best to keep the riddle alive. Keep these great questions in front of us. And to me, that's sustaining. It's like, I don't know how this is going to work, and I don't know. But to have the aliveness and curiosity of the question. But I think there's another point that Diane and BJ are also talking about is community. And one of the things that has always been so important for our center is we don't want to just have a training program. We, get together twice a week and sit together and talk to each other and come on retreat together twice a month. And so, twice a year. And so that it's so important to have, and that it shouldn't be special to our center, that there should be spaces like that in every neighborhood, really. And that's one of the things that we're trying to do and push forward. And do we know how to do that? No. It's an impossible task, and yet we can vow to step forward. Thanks.
Employed at St. Luke's Roosevelt in the outpatient psychiatry department, and I understand that may be there may be a department coming for palliative care. So I imagine that has its own community also. Don't know. Thank you.
I think I'm seeing an opportunity for real support in that, in a sense, because of who we are temperamentally, we're kind of our own worst enemy. We are, as a group, I think we're fantastic at small-scale wisdom and small-scale interactions and making interpersonal change with our immediate surroundings, with our patients, but very few of us have the wisdom and the big connection that you do, Diane, for getting this into large organizational health systems change. And this, I think, is where we need to learn from each other and support each other, that this is something that we need, and the skills that brought us into this work aren't necessarily the skills that we need to go out into the bigger work.
So I'd just like to, a quick response to that is, yes, there are most of us in this room probably don't have the capacity or the energy that, say, Diane has or others. But if it weren't for the people in this room and for all the other people that this is important to, then she wouldn't have a cause, right? So there's always going to be those of us that can work towards facilitating change, but we're facilitating change for others, right? We're doing it because people want it. So we all have our piece of the pie, whichever way it is, and even if it's just working in that department every day and trying to make change. So to not get disheartened, I think it's great.
Mm-hmm. Just a quick observation. It's kind of like we're part of an emergent movement that is going on, and this part of our conversation is about, we're just looking at ourselves. I mean, we're like a bubble that is popping out of the stream that is moving. We're part of a movement. The fact that we're here and that we're making connections here will change what we do next month. So it is important to strategize, and it is important to ask these questions because that sharpens us. And so we can become more aware of what we're doing one-on-one in the room. But the change is happening, and as we become more aware, we can help more.
So I just would like to share a little bit of what I learned. Hit the pause button, collect yourself. Ask, what's your understanding of the situation? Listen, actively listen. Respectfully communicate and accept the outcome. This can be done for patients, but I realize it can be done to a difficult oncologist who wants to give chemo, to a difficult board director who does not believe in palliative care. So we could use it could be used to my mother-in-law. So, it starts with individual, but ultimately, you as an institution could use the hit the pause button. Actively listen. What's this? So to talk to the government. So I believe that cultural change starts with the individual, but transforms into the institutions. And I love to have some big picture people here to guide us. But we also, the small picture people, have a role because he who saves one person also saves the world. Thank you very much.
Trying to be mindful about what I'm going to say and how I'm going to say it, right? I get uncomfortable when I feel too much self-congratulation about myself and my work, and even to put it out there and be a bit brisk about it here a bit too. Why, I ask myself about it, I go back to intentionality, right? Am I going to the room to be compassionate? What am I trying to do when I'm in this work? Why am I doing this work? Why are we here? Am I hoping that I'll look compassionate, that I'll feel like a compassionate person, and that's an image I want of myself that I'm sort of feeding? Because that feels like ego to me. For me, in my own work, the reason why I do it, I think, or continue to do it, is that it brings the question to my face all the time, like, how am I going to live? Like, I can live any way I want, and like, what's important? And seeing people that I know could be me and will be me in one way or another, brings back to me what matters, and maybe there's a small thing I can do to help, maybe not. I often cause harm, actually, with what I say and do. Not that I want to. But it's a complicated process, and intentionality, as long as I'm not trying to be compassionate or trying to be this or that, if I can just sort of come back to that I'm doing this work because it's helping me live out the question of how am I going to live. When I really come back to that, then I think the right things tend to come out more often, and that compassion emerges. Like, I can't make myself be compassionate, and the minute I open up and I'm understanding, I stop blaming the oncologist, and I stop blaming the cardiologist, and I stop blaming if only they would listen to me, and if only the government would do this or that. Of course, they're operating from their understanding system, as I am operating from mine, and my anger dissolves the more I understand where they're coming from. Like if I just really listen to where they're coming from, they're not doing it, it's not about me, they're not trying to be obstructive to me, they're not trying to be obstructive to palliative care, they're not trying to make dying people have a harder time. They understand that the best way it can be done. So if I understand that, and I no longer feel angry, I'm much more able to connect with them and see where there's clearly commonalities, because there is commonalities, because they also want to do good for people also. So, I don't know. That's what I wanted to say. I don't know what it means, but.
So what was the difficulty there? That was beautiful. I mean, that was, for me anyway, I see that as right there on the money. You know, it's not about wanting to be seen as something special because you're doing something that's really important. It's not about me. It's about everybody. You know, I'm not doing this because I want you to see me as a compassionate person. I have in me something that's moving me towards change. But I hope it's bigger than I am, really.
Yeah, but I think maybe you're also bringing up the poisons, right? You know, from a Buddhist view, we're not totally pure, right? Even our intentions to be compassionate and mindful can be really stinky, right? And actually kind of horrendous. And, you know, it can become from our own greed, our own grasping at wanting to be something and feel a certain way, or to feel that we're powerful, or to feel that we're powerful because we're so nice. And we're so contemplative, you know? I mean, it's nauseating, right? You know, and so we don't want that. We don't want to walk around like it's a small world, you know, like binky, you know, everything's good, you know. So, but I really appreciate your voice, and I think that's critical to this work, Stephen. So, thank you.
There's a very, very funny, you know those cartoons where you can do a script and they have little creatures saying what you say? There's a very funny one that our colleagues Eric Wadera and Alex Smith did that I wish I could remember the link to, but it's using these palliative care mindfulness principles when your wife asks you to take out the garbage. You know, take out the garbage. What has brought that to your mind at this time? I just want you to take out the garbage. I can understand how this could be quite upsetting. I'll try to send the link to you guys and you can send it to everyone else. So, like, don't use this at home.
Well, if I may, just to say that one of the best instructions I ever heard in terms of looking at your meditation practice was, you know, it's not from me, it's from somebody else, is don't tell me about how it is on the cushion. I don't want to hear about all your great experiences and how much you practice, how many courses you've taken, how many retreats you've been to. You know, tell me, how was it at Christmas time last year with your whole family? How are things with you and your mother? How are things with you and your father? That's where the practice is. That's where the edges are met.
Beautifully said.
I very much like what he was saying. I think the thing that's coming up for me is how the contemplative practices are coming in from all angles, everywhere these days, and that's what excites me so much. So when I think of the times when I feel like, how is this going to happen? I have such faith in the unfolding and have really that confidence that just what Roshi was saying, that this conversation and that conversation and this connection and that connection are going to be interweaving and broadening out over time. And we may not be here to see the fruits, but we can experience that inside of ourselves just knowing that. One of the things that brings me such a sense of hope is that mindfulness practices and contemplative practices increasingly are being introduced to our children and to our parents. And I think, I look around the room and there are many young people here, and I didn't come, I didn't know anything about these kinds of things until I was, well into my 30s and 40s. And so to have the introduction sooner, have it be part of the bigger conversation sooner, is going to have an effect. It already is, like you were saying. And so it's, what do I want to see? I can see a lot of dark, and I get very discouraged, but I also have to keep reminding myself of what I see that is positive, and that is about the change that is much, much more wholesome. So thank you so much for this.
There's some extraordinary teachers in this group who actually don't do work in hospitals and hospices, who are going back, and so there's seeds everywhere.
Anyone else? Just to follow up on what you just said, and what I think the first person said, I think we also need to be very aware of who's not here and whom we need to bring in. I think it's really an important part of the change, and that is something we can do something about. Yeah. Oh, there's two in the back there. One.
Hi. Just to pick up actually both of what you had said, I like to think that we're really moving along and we're progressing, all of us people. And we're not missing along the way, and that our arms have gotten wider, and we're spreading out, and we're noticing literally everyone in our path. I do a lot of work, and I spend most of my time on the street and with my eyes wide open and noticing everything. And I've raised my son to do the same. And I think that that's the practice, is that you are paying attention. And the people I work with, which are mostly street people or people who are really struggling very much, I am there with them, and I'm learning so much, and have been. And I think that kind of practice, if it's genuine, and it's genuine when you are making necklaces out of seeds that you find on the ground, and they're wearing them, and you're wearing it, and it's exciting to see that. So I think that there's a lot of hope. We have to keep talking.
Thank you.
This has been a wonderful experience, and I am a newcomer, but I feel already a little old in it. And I just wanted to say that in my own private practice of psychotherapy, I believe very firmly that modeling is not enough. Modeling is a start, but understanding and education, what works both ways, to be the teacher and the taught, and to be educated and to educate, is crucial, and that's what we're doing here. So when I hear the word modeling, I'm not averse to it, but I do think it is the beginning. And I think in real life, among possible adversaries, doctors, nurses, social workers, young, old, whatever, that modeling is a good start. But I do think communication and education, to be educated and to educate, is the follow-up, which is what I'm learning here as well. So thank you.
Thank you. There's right here.
Yes, sort of on that same vein, I guess the question that keeps coming to my mind is like, what will the cold, hard specifics be? First of all, it sounds like there's already some studies, but do there need to be more studies to prove that the contemplative doctor who's been trained saves money because they can send patients to hospice earlier and hospice saves money, ergo this doctor saves money? sounds like there are some of those, or do there need to be more studies, first and foremost, to establish in a proven way? I think we're all convinced it's a better way, but monetarily, is it a better way, clearly? So I guess I wonder, first, does there need to be studies? Two, then do you guys, I guess just wondering how you guys imagine, like clearly within the next year or 2 year or 5 years, would it be like a training for doctors who then can decrease their insurance because they decrease the amount of time people stay in the hospital? Would it be more in-home visits? Would it be, I don't know, would it be a meditation room created and then a community of the hospital, people starting to come together? I guess I just wanted to think and ask you guys, those are things I just brainstormed over the weekend, but what you guys think the actual next thing would be very specifically in real world, in real time.
Good question for the doctors on the panel.
Yeah, here, BJ.
That is a great question, and it's tough. I mean, from where I sit in my role at Zen Hospice Project, apropos some of the things we're talking about, I'm learning that I can't. I keep wanting to do too much, just because there's too much to do, not some megalomania. But I think I could do this field and our community the best by focusing on a few things. So for me, it's really honing in on residential hospice care, knowing that most people want to die at home, but that many people can't. And right now the options are nursing home or find yourself back in the ER, and those are just so deeply unsatisfying. So it's building a sort of an argument for an alternative pathway. And we're doing that. So with our relationship, UCSF leases a couple beds from us. They send patients to us who are at the end, who are otherwise languishing in their acute care hospital, frees up acute care beds for them. They make more money. So 1 year partnership on 2 beds, net of what they lease, they made between $500,000 and $1 million. It's a remarkable argument, very useful. And everyone wins, you know. So that kind of sort of relatively hard data. I need to look for those things, and at the same time make a space for things that may not be so amenable to data. There is qualitative research that I'm learning a little bit more about and need to navigate that as well. But one thing is we can't be afraid of data, even though we know not everything can be measured. We need to use it skillfully. So that's sort of one thing I'm focusing on in residential palliative care. Another thing I'd like to focus on is bring our training to home health aides, CNAs, the direct care workforce. That's a big deal, and may go a long way towards inviting people to this conversation who don't otherwise have a seat, like the first question in the group. So there's a few things there, and I think it would be wise for a lot of different organizations to pick a few, 1, 2, or 3 endpoints and work on those things and contribute to a larger movement that way, rather than all of us trying to do everything. But maybe, Josh, do you want to have a follow-up on that? Yeah. Okay, yeah.
Thanks. 2 mics. I was just going to say, I think what you're saying is right on. From the way I see it, it's kind of a good cop, bad cop model, in the sense, contemplative to me means the need to preserve values that cannot be monetized, and as you say, are not amenable to the bottom line. Like, we're doing it because this is good care and it's the right thing to do. Now that's very idealistic. So on the other side, you need data. So I see contemplative as holding that piece, saying, you know, there are things you can't put a dollar sign on, and they're values that we just need to preserve because that's the way to provide care, and that is intrinsically good.
Yeah.
And then the other piece is the guys who are crunching data, who then back it up.
Yeah, well, this is another one of those invitations for a third way. It's not data good, data bad.
Right.
You know,
right.
It's all of the above. Work with it in a dynamic way.
Exactly.
And even if you take a more expensive idea of data around qualitative data, the satisfaction of the physicians who refer their patients to us and actually care how their lives end, their patients' lives end, are so thankful. So let's make sure we interview them and capture that experience. You know.
Yeah.
Did I cut you off, Josh?
No, that's great. Good conversation.
Diane might have a different or more. I'm going to put you on the spot. Did you want to say anything about
more nuanced?
More nuanced, yeah. Let me work on nuance. So this is all I think about, really, is this 30,000-foot question. Like, how do we go from concept to actual as a nation? And if we take as our vision that all people with serious illness have access to high-quality palliative care. So that's the big picture goal for the various segments of this, and I do call it a movement. Then you have to bring it down to then, if that's the vision, then the mission to achieve that vision, the way we framed it is threefold. First, that the public knows what palliative care is and demands it when it's appropriate. So that encompasses this outreach to other communities that are not in this room. That means making sure that African American, Latino, Asian, young, old, poor, rich, fundamentalist, Orthodox Jewish, Muslim communities understand this kind of care and language that speaks to them, and understand what's in it for them. Because in part because public demand is key to getting policy change, so that's part of a tactic, but also without public awareness of what they could be getting but are not currently getting, it's not going to happen. It takes two. So that's the first piece of the mission. The second piece of the mission is that all people working in healthcare have the knowledge and skills to provide palliative care. And we've talked a lot, at least on Thursday night and again today, about how that is not the case. It is not the case that doctors get the training they need to provide this kind of care, or nurses, or social workers, or chaplains, or home health aides, or anybody else in the system. So this notion that somehow we're going to get there without changing how we train and educate people in the healing professions is absurd. And influencing training is unfortunately not simple, because it's not federally controlled. It's actually controlled by guilds that are run by the different disciplines. And those guilds are very hidebound and averse to change. And actually, for the most part, controlled by people who do very well with the system as it is now, and have a stake in not changing it. So there's, again, where public demand is so crucial, because public pressure is probably one of the only things that's going to move for change on how residencies are accredited or how nursing schools are accredited, and that's how you get change there. Then the third component of the mission is that all healthcare entities, hospitals, nursing homes, home care agencies, physician practices, community clinics, have the capacity to deliver palliative care. And so that means influencing accreditation requirements. Like a hospital has to be accredited, a nursing home has to be accredited, a physician's practice has to meet certain guidelines. We need those guidelines to require delivery of high-quality palliative care as a condition of accreditation. So all of these are policy. Then underneath each of those three missions are strategies and tactics to get there. And some of it is data. Some of it is overcoming language like death panels by doing very effective social marketing and investing in PR and communications. Some of it is developing relationships with the people who accredit medical schools and residencies. This is something Charles von Gunten, again, brilliantly did. The reason palliative medicine is a subspecialty is because Charles put himself in the same room as the people who run the decisions about who gets to be a medical specialty. He didn't just hope it would happen. He actually made appointments and sat with them and established relationships, so that then it was their accomplishment, not his. And that's what it takes on all of these different levers. So that's the top-down strategy. The bottom-up strategy, and they feed each other, is that increasingly everywhere you look, there's palliative care. And that drives the policy side, the fact that there are actually 1,700 hospital teams, that nursing homes are turning in this direction, that this group is here, drives the top-down stuff, like this. So it's a like four-dimensional chess game, and it's not boring.
I had a comment. Oh.
Just a second, he's got it, and then you.
If I could just a comment on the question of research and contemplative care, because I think it's a precious question, actually. And I think what we can think about, well, what works for ourselves, what we've noticed, benefits that we've noticed with our own practice, I think it's fair to assume that there may be benefits to others outside of what, that we normally think of, for example, patients, and the impact that could then have. So if we think about change as something that starts with ourselves, our own self-awareness, and then it's spreading out, we can see that not just try to change the system, which seems overwhelming, but what if it can be something like allowing patients to change? And that can then have another ripple effect. So just to make that a little bit more concrete, actually a medical student had approached me about an idea to study mindfulness, meditation, and the impact that could have on quality of life of patients. And so Sagan is working with him in developing a pilot project on teaching patients mindfulness, and then we're going to assess their quality of life, among other things. But one of the things that I think would be an epiphenomenon, which would be very interesting, like the way the meditation practice for myself allows me to make better decisions, allows me to think about my best interests and other people's best interests in a more direct way, in a more immediate way, in a more intimate way. What if that happened with patients too? What if by the simple act of teaching them a mindfulness practice then could allow them to have the conversations that we expect the doctors to have, but they're not having it, so we have to teach the doctors to have them? What if it came from the patients? What if they said, doc, that's not working for me. This is what I need right now. This is what I'm feeling right now. This is what's coming up for me right now. And the courage and the immediacy and the intimacy that can then transform. So we can, I think it's exactly the four-dimensional chess game. I mean, it's thinking of it on all different levels, and we can look at it. How do you change the system? And take this approach. But what about flipping it? What about allowing a patient to change the system? What about allowing ourselves to change in various ways that we can't even measure yet? But in these little ways, if we can start to measure them and see, wow, this is having an impact too, and then slowly chipping away at it, as Bijay was saying, is perhaps maybe the best approach, rather than trying to take it on as a behemoth that we have to sort of tame.
There's one more.
Yes, I just is listening to everything. I think that one of the hardest things for me is I tend to think in black and white, and I hear a lot of that now. We need the darkness in order to have the light. Plants need darkness as well as the light. Well, we need the good as much as the bad. We kind of function in this system of opposites. And part of what I keep on hearing is the way that we work together is in relationship and in intimacy. And that doesn't mean we have to give up the darkness or the light. It doesn't mean that we have to give up one or the other. What it means is we have to work together as a team to develop those intimacies, and then things can exist. You can have the data. I tend to be data-driven, mathematical. I need answers. This unknown kind of creates a discomfort for me. But even by recognizing that, sometimes that allows me to go into where I am uncomfortable, allows me to say, okay, it doesn't have to be data-driven. We can use other things. And I think that that's the change that I'm most hopeful for, is that we learn to live together. We learn to live in relationship, which is very difficult because we have such a power-driven system. The people in power are the ones that get heard.
Thank you very much. I'm afraid that's going to have to be the last one. We got so into this discussion that we've run out of time.